Before we start, let's try to diagnose our client. Female, age 22, comes in with a list of their symptoms and the ways they have changed in the past year or two. 1. Depressed. 2. Anxious. 3. Paranoid. 4. Irritable. 5. Mood swings, within minutes. 6. Can't control emotions, extreme anger, sad and level lonely. 7. Fear of being left, by spouse. 8. Antisocial most of the time, just don't care to talk, normally a people person. 9. Eat things by color, and order, chew equal amounts on both sides. 10. Step on cracks equals same hash for both feet. Same with everything. 11. Can't communicate how I feel very well, becomes a fight. 12. Always get called selfish, that I think the world revolves around me. 13. I see things very black and white, no middle ground. 14. Am very all or nothing, I didn't go to my high school prom cues, I couldn't have the works. 15. Had a few suicide attempts in life, but spouse gets mad at me, so I scratch myself but try not to so he doesn't get upset at me. 16. Super low self-esteem. 17. Can't sleep. 18. Don't really know the difference of who I am and how I act. 19. Gained 20 pounds in past year-ish. 20. Always feel empty. 21. Often called manipulative. 22. Very dramatic, exaggerate drama queen, look for it, am told look for issues. 23. Sometimes I talk in the 3R person. 24. Want all attention. 25. Need to be loved. 26. Not sure if I am oversensitive or whether it's justified. 27. Cry over everything now, never cried before. 28. Blocked out a lot of my past I don't remember. 29. Can never make decisions, even what to eat, I take forever. 30. Stopped caring to socialize with anyone except spouse. 31. Won't even play with spouse or show excitement at concert for fear of looking stupid in front of him, don't know why. 32. Constantly question spouse's love for me. 33. I am a major snoop. 34. Don't trust anyone. 35. Hold grudges. 36. Like my rituals crossroad at the same spot always. 37. Like to give gifts, even if it's just chocolate bars, make people love me. 38. Sex drive fluctuates, really want, really don't. 39. Very controlling-ish. 40. Eat too much when sad, bored, that's why I am a cow. 41. Get jealous at the idea of my spouse doing himself, dumb. 42. Get bored easily, but am super lazy. 43. I fall apart constantly, my thoughts just take control and don't let go. 44. I need to plan far ahead, cues I can't control now. 45. Feel so empty. 46. Ruined my relationship, try to be nice but things happen, don't know why. 47. Fear of fish. 48. Judgmental. 49. Opinionated. She presented as a young bespectacled woman who was neatly and appropriately dressed and neatly groomed. She was spontaneous with her responses and spoke quite openly about her difficulties. She smiled quite often and her affect was fairly cheerful. Some idiosyncratic thinking is noted, but she is in touch with reality and is therefore not psychotic. No perceptual abnormalities were noted. She was not suicidal or homicidal. She was fully oriented, her cognitive functioning appeared to be within normal and her intelligence was estimated as average. What diagnosis do you see? Messy, isn't it? This client presents with mixed personality disorder with borderline, narcissistic, and histrionic features. Also, she has symptoms consistent with obsessive compulsive disorder. We will focus on borderline personality disorder. The criterion for BPD is as follows. a pervasive pattern of instability of interpersonal relationships, self-image, and affects, and marked impulsivity, beginning in early adulthood and present in a variety of contexts, as indicated by 5, or more of the following. 1. Frantic efforts to avoid real or imagined abandonment. 2. A pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and evaluation. 3. Identity disturbance, markedly and persistently unstable self-image or sense of self. 4. Impulsivity in at least 2 areas that are potentially self-damaging, for example, substance abuse, binge eating, and reckless driving. 5. Recurrent suicidal behavior, gestures, or threats, or self-mutilating behavior. 6. Affective instability due to a marked reactivity of mood, for example, intense episodic dysphoria, irritability, or anxiety usually lasting a few hours and only rarely more than a few days. 7. Chronic feelings of emptiness. 8. Inappropriate, intense anger or difficulty controlling anger, for example, frequent displays of temper, constant anger, recurrent physical fights. 9. Transient, stress-related paranoid ideation or severe dissociative symptoms. The stigma. The diagnosis of borderline personality disorder brings a lot of stigma and negative feelings to the individual diagnosed, not just by society, but by their doctors and the mental health nurses as well. It was found by Nels that people with the borderline label have been called not sick, manipulative, non-compliant, time wasters, difficult, bed wasters, not mentally ill, and attention-seeking. In a study from Dominic Markham, 2003, RMNs and HCAs both rated significantly higher on wanting social distance from those with BPD compared to individuals with depression. RMNs also rated significantly higher than people suffering from schizophrenia. RMNs and HCA's opinions of the dangerousness of individuals with BPD were significantly higher than those who had depression, and once again RMNs rated significantly higher than those with schizophrenia. Their optimism ratings were significantly lower for BPD than both depression and schizophrenia. When people with BPD go to their therapy session and are faced with the negativity of the nurses, or doctors, it places a strain on the therapeutic relationship, causes the borderline more stress and anxiety, and this is in turn perceived as more acting out in the nurse's eyes, causing a vicious circle in which the borderline may just quit their treatment. There is no empirical evidence that states borderlines are any more violent or dangerous than other client groups. It is also more likely that an individual with BPD would hurt themselves before hurting another. There is evidence that those with BPD are difficult, but there is little reason to stigmatize these individuals with harsh shame and guilt for their symptoms. It is not done for the other disorders. These nurses seem to think that the behavior exuberated by the borderlines is deliberate and that they are bad due to it, but as research shows, if a schizophrenic were to do something destructive, they are not viewed unsympathetically as BPDers are. Frazier and Gallup found that nurses see borderline are deliberately sabotaging their treatment, but it is hard to focus on treatment when you feel judgment from those you are hoping to help you. Prognosis. The rates of improving are much more positive than what nurses are apparently feeling and reacting to. Most patients diagnosed with BPD get better with time. By about 35-40 years old, 75% of these patients will have regained close to their normal functioning. By the time they are 50-90% will have recovered. Often symptoms decrease as age increases. It is not understood exactly why this happens, but it is theorized that as their life becomes more stable with relationships and money, and they have the structure they need, they are able to learn how to deal with stressors and how to avoid situations that cause issues better. Negative or pessimistic attitude are only detrimental to the patient mental health, as it is not a helpful response to any situation. And this deficiency in proper care for those in need shows a lack of knowledge and special skills in how to work with individuals with BPD or personality disorders in general. The stigma of bad should not be put on those afflicted with issues caused by their disorder, It should be placed on those who are supposed to be part of a support network and are neglecting their duty to be supportive and judgment-free. Alternative ways to look at the criteria or symptoms. 1. Extremely loyal and communicative of relationship needs. Willing to make sacrifices to hold on to what is precious. 2. Love deeply and without reservation. Passionate. Able to see both the positive and negative of all things. Not afraid to release their feelings toward these extremes rather than holding in what bothers them. They are expressive. 3. Fluid in their identities and open to new experiences. A borderline's self is highly adaptive in order to facilitate relations with more rigidly defined others. They are not afraid to change and adapt to their environment. 4. Open-minded to new experiences. A deep urge to explore the ecstatic heights and depths of human experience even at the expense of personal risk. 5. Express feelings strongly. Feel very deeply, and do not fear their emotions or the expression of them. 6. Don't sweep things under the rug. Able to experience the full emotional spectrum more than nearly anyone. 7. In touch with the existential darkness. A deep-seated thirst for meaningful relationships and experiences that is not easily satisfied with artificial substitutes. 8. Strong adverse reactions to injustice or abuse that sometimes transfers across time and place or individual boundaries. Does not fear saying that they are upset. Ability to speak up for themselves. 9. Very sensitive to their environment. Borderlines realize that there is no reality, and that the world around us is all designed by our perceptions. This can cross the line. More positives. Insightful. Studies on BPD indicated that because of their own hypersensitivity and pain, some people with BPD may easily connect to what is around them. People with BPD may take experiences like these and emotions and turn it into insight, a high level of empathy and understanding to others. Curious. Observations and studies show unusually high curiosity is common in some people with BPD from the hypersensitivity and connectivity with their emotions, senses, and surroundings. High awareness. As a result of being hypersensitive and easily connected to surroundings and outside stimuli, some people with BPD have been observed to have high awareness. Such strong emotions and connections may call for or reinforce high awareness. People with BPD have been observed to have a high level of comfort, security, and connection to nature and animals, such as pets. Dependent. Dependency can be a good thing with a proper balance, like for support, closeness, affection, and interconnectivity. Protective. Aggression isn't always a bad thing. Aggression can mean protective of someone or the self. Loving/appreciative. Some people with BPD may idealize and glorify another individual in their life because of such strong emotions, reactions, and needs, and they may also be very appreciative because of hypersensitivity and painful experiences. Loyal. Idealization, dependency, hypersensitivity, etc. Such reactions and features may prompt strong loyalty and devotion. Creative. An unusually high amount of writers have BPD. High levels of creativity were linked to some individuals with BPD in research cases. New ideas, artistic or musical ability, writing, or other areas of creativity. High pain tolerance. Studies indicate an alteration in acute pain processing. They have a higher tolerance for such. Individuals with BPD were far more likely to tolerate it, despite being hypersensitive psychologically. The result of this comes from different systematic responses and anti-nociception and may be a result of long-term self-harm behavior in some cases. Discipline. Research observes that with the proper balance and use, people with BPD may also display high levels of self-discipline, work orientation, and drive connected to these features of perfectionism, repetition, etc. Sarcastic/funny. The DSM and other observations state some people with BPD may often express sarcasm and humor. Alluring/interesting. Such extreme reactions and expressions are shown or felt to others. Because of the intensity, many people note the interesting and or alluring behavior or energy of someone with BPD in observation. Strong. On a psychological level, people with BPD are often described as feeling the sum of the most intense, agonizing reactions, and one needs to be quite strong to handle them. Treatment. 1. Dialectical behavior therapy, DBT, focuses on the concept of mindfulness. DBT teaches skills to control intense emotions, reduce self-destructive behavior, manage distress, and improve relationships. It seeks a balance between accepting and changing behaviors. This approach was designed specifically to treat BPD. DBT is the most studied treatment for BPD and the one shown to be most effective. DBT requires at least a 6-month to a year-long commitment. It's highly structured and takes 6 months to go through all the modules in a skills group once. It's more effective for clients to practice these stages a second time to cement skills before they start addressing any trauma. The first stage addresses suicide and self-harming behavior. Stage 2 involves treating emotional trauma from the past. Stages 3 and 4 help clients work on problems of real-world living and to develop their capacity for joy and a sense of being comfortably at home in the universe. The therapist needs to appreciate the reality of the client's emotions. BPD patients require emotional acceptance, a DBT staple, because they often lacked it as children. In an invalidating environment, for example, a child might express anger and be told by a parent that she is jealous. They never gain a sense that their needs, wants and desires are reasonable. These circumstances can lead to emotional difficulties and a problematic sense of self. DBT helps these people restore their sense of self, and legitimizes their emotional experience. 2. Minimalization-based therapy, MBT, is a talk therapy that helps people identify and understand what others might be thinking and feeling. 3. Transference-focused therapy, TFP, is designed to help patients understand their emotions and interpersonal problems through the relationship between the patient and therapist. Patients then apply the insights they learn to other situations. 4. Good psychiatric management, GPM, provides mental health professionals an easy-to-adopt toolbox for patients with severe personality disorders. 5. Medications cannot cure BPD but can help treat other conditions that often accompany BPD, such as depression, impulsivity, and anxiety. 6. Self-care activities include regular exercise, good sleep habits, a nutritious diet, taking medications as prescribed, and healthy stress management. Good self-care can help to reduce common symptoms of BPD such as mood changes, impulsive behavior, and irritability. Challenges to treatment for borderlines and their therapist. Borderlines frequently seek out help, but they also tend to drop out of therapy. They're quick to open up to a therapist, and perhaps even quicker at shutting down. A borderline person can be so distressed at the end of the hour that the therapist will agree to call later in the evening or see them later in the day. This can devolve into a 24-hour availability and lead to burnout. The borderline's constant crises, demands, and mood fluctuations can frustrate and wear out the therapist. Promises that the therapist may not be able to keep, is extremely injurious to the client, e.g. promising never to leave a borderline. The therapist can fear emotional fallout that might occur during their client's session, or they are afraid they'll lose the client, if they confront them with this information. The borderlines' need to control their relationships may prevent them from starting this reparative process, or derail their ability to stick with the work and fully recover. Non-compliance with treatment is common for borderlines. Aside from their fear of change, they rebel against useful intervention. Transference and countertransference due to the underlying stigma from a very narrow and stereotypical notion of how BPD features present in impaired individuals, and what borderline personality disorder actually means or entails. A common misconception is that all borderlines were molested or incested as children. Sexual abuse does not cause BPD. The borderline may develop roles they've come to use within their everyday life, which allow them to navigate on autopilot and perform spousal, parental or professional tasks, while being disconnected from any genuine emotions and needs. In a sense, they're sleepwalking, but their role play gives them a much needed sense of containment, and helps them adhere to socially acceptable limits and boundaries, so they can maintain some semblance of order and functionality.